Hi everyone, and thanks so much for joining us in the Latte Lounge on World Menopause Day for this very unique event with a special guest and author of the best-selling book, Oestrogen Matters. Hope you can all see that. Now, Dr. Bluming is joining us all the way from his home in Los Angeles. But before I introduce Avrum, I just wanted to run through a few housekeeping instructions. We are recording this so that we can send you it after the event. So if you don't want to be recorded, please do turn off your cameras. And if you can also just keep your mics off so that we don't pick up any noise from the background. Also, it might help if you put us on speaker view so that when Avrum or I are talking, you can see us more clearly. Now, if you have any questions, please put them in the chat box and we'll try to get through as many as we can. And if we run out of time, please feel free to email me and I'll do my very best to get them answered for you. Obviously, Avrum can't answer any very personal medical history questions, but we'll do our best to signpost you all for next steps. So before we get going, I'd also just like to thank our sponsor, Silk Natural Lubricant, for making tonight's event possible. Silk's plant-based formula works in harmony with your body. It's made in New Zealand, and Silk soothes vaginal dryness, which is often caused due to perimenopause or menopause symptoms. It can also be a side effect of cancer treatment. And if anybody would like a free sample, just email info@silk.co.uk. And we've also got 20% offer on our website, which is lattelounge.co. So, without further hesitation, I'd like to now officially introduce you all to Avrum. Dr. Avrum Bluming is a hematologist. He's a medical oncologist and a clinical professor of medicine at the University of Southern California. He's a former senior investigator for the National Cancer Institute and a master of the American College of Physicians. This is an honor bestowed on fewer than 500 of the 100,000 board-certified internists in the US. And Avrum, of course, is the author of the best-selling book, Oestrogen Matters, which he wrote with Carol Tarvis. Carol's a social psychologist, and she's a writer who's won numerous awards for her writings about psychological science, skepticism, and gender equality. So welcome, Avrum. Can you hear me?
I can, Katie. Thank you very much.
Oh, it's just wonderful to have you all here with us today, Avrum. So before we talk, I think you just want to say a few words quickly at the beginning.
Yes, well, it should be stated, since we're going to be talking about hormone replacement therapy, that I receive absolutely no funding or gifts from any pharmaceutical company, nor have I ever. I have no conflict of interest on this. I am interested only in helping to provide information that can improve women's longevity, improve the quality of their lives, and decrease their risk of heart disease, hip fracture, and cognitive decline.
Thank you for that. So, look, talking of which, before we get going talking about your book, can you just explain a little bit to everyone who's watching why you wrote it, and more importantly, what happens to us women, during midlife? What happens to our hormones, and what actually is HRT?
Sure. This is the first and thus far the only book I've ever written. I usually write articles that are published in peer-reviewed medical journals. And about 60% of my oncology practice has been devoted to breast cancer because that's been the most common cancer that I've seen. And I've watched the field improve so that the cure rate now for newly diagnosed breast cancer is approximately 90%, which is wonderful. And many of the women I treated after they survived breast cancer and got older and older started complaining to me about the symptoms of menopause. We all know about hot flashes and night sweats, but they were complaining about palpitations, about depression, about increased girth around the waist, about marked anxiety attacks, and I wasn't sure these were due to their menopause state, but my stock answer was, well, you're alive. You've survived breast cancer. Why aren't you happy? And it would explain to me that I really didn't understand how severely their symptoms were impacting their quality of life. One of those women happened to be my 45-year-old wife. And although she is very stoic, she took it and would explain to me what she was going through. And after hearing that for years, I started looking into whether or not hormone replacement therapy can be given to women who survived breast cancer. And in answer to your question, hormone replacement therapy is really replacement of estrogen, which when a woman reaches menopause, falls rapidly within a few years to 1% of her premenopausal circulating level. Testosterone falls in aging men, but at a much, much slower rate. And although there is a condition called andropause, which is the male equivalent of menopause, it is hardly discussed or looked at and doesn't impact, as best I can tell, the quality of life the way menopause does for women. And what I found is that although it was simple to say that estrogen causes breast cancer, it is not only simple, it is somehow satisfying. If estrogen causes breast cancer and I had breast cancer, then if I stay away from estrogen, I'll be fine. But it's wrong. Estrogen doesn't cause breast cancer. And the more I looked into it, the more convinced I became that that simple answer was depriving women of what could prolong their lives in addition to improving the quality of their lives. Progesterone, which is the second hormone that is used only in women who still have a uterus, because when estrogen started to be used as replacement therapy in the 70s, the incidence of uterine cancer started to rise dramatically, up to about 5-fold. And so estrogen use decreased, and then we found that progesterone given to women as part of hormone replacement therapy nullified that increased risk in uterine cancer. So hormone replacement therapy refers to estrogen primarily and progesterone only in women who still have a uterus.
So you've answered, so the first chapter of your book actually is, does estrogen cause breast cancer? And you've actually pretty much answered, that for us. Yes.
I answered it with a broad statement.
Yeah.
Obviously in the book, it is answered with referenced and detailed studies showing that, in fact, it doesn't cause cancer. And it might be worth adding one other thing, and we'll get to this later. The reason estrogen use plummeted around the world was primarily because of a $1 billion study called the Women's Health Initiative that was first published in the United States and around the world in 2002. And they just reported their 20-year follow-up. And their 20-year follow-up says, not only does estrogen not induce breast cancer or increase the risk of breast cancer, estrogen decreases the risk of breast cancer by up to 30% and decreases death from breast cancer as well.
Well, that's quite incredible, and we are going to talk actually a little bit at the end about that report, because it's responsible for pretty much everything that's gone wrong. But in your book, you go on to talk about quality of the change of life and quality of life, and you very kindly quoted my own story on page 70 and 71 about how I sort of struggled for 4 years with perimenopausal depression, which was misdiagnosed, as everybody knows, as depression. And like so many women that we hear from all the time, I was sent to cardiologists, I was sent to dementia specialists, I was made to feel crazy. And in your book, you actually talk about this happening to Oprah Winfrey and how she was sent to 5 cardiologists because she was having heart palpitations. So talk to me a little bit about, length of life and quality of life and why it is so important, during this time.
Well, what is unusual is not that women develop symptoms when they reach menopause, which is usually between about 48 and 55. What is unusual is that women survive into their late 70s and 80s. At the turn of the last century, less than 5% of women in developed countries survived beyond age 55. And now they're surviving into their 8th decade. And I mentioned that estrogen falls to 1% very shortly after they turn menopause. It would be worth thinking about what would happen if men had similar symptoms to women around that age. And what if we said to men, yeah, you have hot sweats and hot flashes and night sweats, and forget your sex life, and even when you can convince somebody to have sex, it's painful, and you have palpitations, and yeah, it might shorten your life, but buck up. You're a guy, deal with it. There is no chance, Katie, that men would accept that advice. And women have.
And it's absolutely shocking. I mean, to me, it's almost like medical negligence, what's going on. And we all know why, that is. I work with a lovely lady called Diane Danzibrink, who has launched a petition in the UK, hashtag Make Menopause Matter, which we're actually asking everyone today to sign if they haven't. And one of the reasons she set it up, and I'm sure it's exactly the same in the States, is that there are just so many healthcare professionals that have not had much training, if any, about peri-menopause and menopause. And obviously they were also frightened by the WHI report in terms of the safety of prescribing HRT. And what happens is that we all end up suffering unnecessarily, and it's absolutely shocking. And Avrum, the other thing that a lot of women don't know, and if you could talk to us in your next chapter, you talk about matters of the heart. And heart disease is the biggest killer of women in this country, and yet we don't talk about it. It's men that you hear about. But estrogen helps with heart disease, is that right?
That's an understatement. The heart disease kills 7 times as many women as does breast cancer. And when I say that, what women usually say to me is, well, I'm not really afraid of heart disease, because heart disease is responsible for the death of older women and breast cancer kills younger women. But in fact, from the age of 40 on, more women die in each decade of heart disease than die of breast cancer. And that difference grows as a woman ages. And numerous studies have shown that estrogen administration decreases the incidence of serious heart disease by up to 50%. 50%. In 1991, Lee Goldman, who at the time was at Harvard and then became the dean of Columbia Medical School, wrote an editorial in the New England Journal of Medicine in which he spoke about giving estrogen to peri and menopausal women. And the title of the editorial was Time for Action, Not Debate. That was 1991. That was almost 30 years ago. And the data have become stronger with time.
It's absolutely shocking. I mean, a lot of women get sort of scared and they talk about alternatives. How does it compare to things like statins or watching your diet or, fitness? Obviously, we need to do all of those things, but taking estrogen for, reducing the risk of heart disease versus statins, is there a big difference?
Yes, significant, in favor of estrogen. Estrogen is more effective than statins in preventing serious heart disease. Statins may even work somewhat better in men than it does in women, but like with many studies, we have extrapolated what we know about men to women without necessarily doing the data research required to make sure it's appropriate to women.
It's quite unbelievable. I think a lot of women just don't know about these benefits. And talking of benefits, in your next chapter, you go on. I mean, I love the next chapter title is called Breaking Bad. Now, we're not talking about meth labs here. We're talking about how estrogen prevents our bones from weakening, which is osteoporosis. And actually, we've had quite a lot of emails in about osteoporosis. So does it cure it? Does it reverse it? How does the benefits of estrogen on our bones help?
It prevents it. But let's talk about what osteoporosis is. Many people, and this includes physicians, think that osteoporosis is calcium deficiency. And so treating with calcium and vitamin D is proposed and widely advertised as a way of preventing osteoporosis. And osteoporosis isn't just a long word. In fact, it's responsible for hip fracture, which causes as many female deaths each year as does breast cancer. The same number of women will die within a year of a hip fracture as will die of breast cancer. And that's just sort of accepted, and it shouldn't be. And osteoporosis isn't really calcium deficiency. Calcium helps make stronger the cortex or the outer part of bone. And that's an important thing. And if you want to make the outer part of your bones stronger, what you should do, and I'm not suggesting this, I'm just saying this for the sake of argument, you should take fluoride. And fluoride will dramatically increase the density of your bone, and by the way, will increase your risk of bone fracture. Osteoporosis really is a failure of the inner girders of bone, not the outside shell, but the inner girders which weave together to give bone its tensile strength, which means how much bone can bend without breaking. And taking estrogen preserves the tensile strength of bone. If you don't preserve the tensile strength of bone, taking a lot of calcium and vitamin D will do nothing, and has done nothing in postmenopausal women not on hormones to prevent hip fracture.
And if women have something like a DEXA scan to have a look at their bone density or bone resilience, and if they see they're starting to deteriorate, can you then actually see, once you start taking estrogen, that it becomes, the bones start to become stronger, or is it too late by then?
It's probably not too late, but a bone mineral density is not looking at bone tensile strength. It's looking at the density of that outer shell. And it is viewed as the best, albeit imperfect, test for osteoporosis. Obviously, the best test would be to take somebody's forearm and put it in a vise and see how much pressure you have to apply before you snap the bone. And clearly, we can't do that. Engineers are able to test bridges for tensile strength, and I don't know, only because I'm not smart enough, why we can't do that for bone. We know that the bone mineral density has some correlation. It's imperfect, but it has some correlation with fracture, and so it is used as a test to see if a woman is beginning to lose her density and perhaps should start hormones at that point. The problem with bone mineral density, it has created the diagnosis of osteopenia, which isn't osteoporosis. It means your bone mineral density is a little less dense than normal, but it doesn't reach the criteria we've set up for osteoporosis. And in fact, osteopenia has no clinical significance. There is no relationship between a diagnosis of osteopenia and a risk of fracture.
Wow, I mean, a lot of food for thought here. And as a lot of people are probably starting to realize, the reason I'm going through the book in this way is because you can start to see how many enormous benefits there are for actually taking HRT. And a lot of women have obviously joined us, because they're particularly worried about being breast cancer survivors, or have had breast cancer or have it now. And I am going to go on to talk about that. But the next chapter in your book is entitled Losing and Using Our Minds. And this is something, that I really struggled with, that it wasn't just the low mood, that I was forgetting words, and I had this brain fog, and you could only describe it as sort of walking in sort of thick treacle. And we get women, come to us all the time thinking that they're going mad, and it's just part of growing old, and and they're sent off for tests for early, dementia. Again, estrogen, it reduces. Is it proven to reduce dementia in women?
Yes. The incidence of Alzheimer's disease is twice as common as the incidence of breast cancer. And while currently diagnosed breast cancer is 90% curable. Let me say that again. Currently diagnosed breast cancer is 90% curable. There is no cure, and there is no treatment that works for Alzheimer's disease, except estrogen, which when given prophylactically, meaning before a woman starts to decline cognitively, has between a 25 and 65% chance of reducing or preventing cognitive decline. If women are afraid of one thing more than breast cancer, it's cognitive decline.
And I think a lot of people, because I'm starting to think this now, why aren't women written to at the age of 40 with a letter with a symptom checklist to say, are you feeling X, Y, and Z? Why aren't we actually all just given HRT from the age of 40? Because to me, it sounds like a no-brainer.
Ananda Cole is an epidemiologist who was working at Tufts and then at Harvard. And in 1999, she published a study asking that question and came up with the conclusion based on the data that she could amass in 1999, and said that if all women in the United States started estrogen around the time of menopause, 48 to 53, 98% of them would benefit, and their survival would be increased a median of 3.3 years. Roger Lobo, a gynecologist at Columbia in New York, said in 2012 that women's longevity would be improved by 20 to 40% if they were put on hormones. And clearly, as you mentioned in the beginning, this has to be individualized. These aren't M&Ms that we're peddling to people. But when you go into a doctor to discuss it, have information at your fingertips so your questions are not simply dismissed as yours were, Katie.
Yeah. And I want to talk to you about whether breast cancer survivors can take estrogen, but I'd also like to go back to the beginning. There's an introduction in your book, Who Killed HRT? And in the 90s, the medical consensus, as you've said, was fairly strong regarding the benefits of estrogen therapy and hormone replacement therapy. And then this WHI report was published in 2002, and it said there was an increased risk of breast cancer, heart disease, stroke, dementia, and hundreds of thousands of women just immediately came off it, and their doctors supported that decision. What went wrong? Why did that happen? And it is obviously responsible for the mess we're all in now.
There were other studies before that, but that's $1 billion study, and that's the one that made the difference. And ironically, Bernadine Healy, who was and thus far is the only female to run the National Institutes of Health in the United States, was responsible for getting the Women's Health Initiative off the ground because she objected to the fact that most studies were done on men and results extrapolated to women. And she wrote a book in 1995 saying, based on everything I know, women have an advantage over men regarding bone health and heart health and brain health. And so as soon as I reach menopause, I plan to start hormones without a blink. Sadly, she has died, and she would be so aggravated by what the Women's Health Initiative has done with what she helped generate. First, the Women's Health Initiative said, we are going to study women and extrapolate results to all healthy women. The median age of the women in the Women's Health Initiative was 63. 70% of them were overweight and half of them were obese. Half of them were either current or previous smokers, and 35% were being treated for high blood pressure. Let me say again, the median age was 63. Less than 10% were between 50 and 60. And what they found is an increased risk of heart disease, stroke, Alzheimer's disease, yes. Every one of those findings, those three, heart, bone, and Alzheimer's disease, heart, stroke, and Alzheimer's disease, have been walked back by the same investigators in the literature, to the point where they write in their articles, we're glad to announce that in fact, women don't have to be that afraid of hormones, without having the kind of huge press release that their 2002 article generated that helps put women at ease. The incidence of hormone replacement therapy prescriptions in the United States went from 48% to less than 5%. A study out of Yale by Phil Sorrell and Howard Hodis that was published 5 years ago said that in the United States, at least 50,000 women have died prematurely as a result of that study. And that number, according to Dr. Sorrell, whom I spoke to today, has now more than doubled. The reason the study generated so much headlines, however, was not because of heart disease or stroke or Alzheimer's disease. It was because they said there's a dramatic increased risk of breast cancer. Really? Well, first, and let me say this by jumping to the end, a 19-year update of the Women's Health Initiative that was just published this year reported that estrogen alone was found to decrease the risk of breast cancer by about 30% and decrease the risk of death from breast cancer by 30%. And you haven't seen that headline anywhere. What they, and their initial report that said increases the risk of breast cancer, which was also a headline in the New York Times, did not find a significant increased risk of breast cancer. And so I invited Rowan Schlabowski, one of the principal investigators of the Women's Health Initiative, to my local hospital in California. And I asked him to explain to the medical audience why prescription incidence had fallen so dramatically. And at the end of his explanation, one doctor stood up and said, you know, I'm just an ENT physician. He didn't say, but I have a PhD in mathematics. And so this is a little above me, but it seems to me that the numbers you presented aren't even statistically significant for the increased risk of breast cancer that generated all this tumult. What am I missing? And the doctor said, you know, he said, this is the biggest study ever done. By the time we're finished, he said, it will cost $800,000. It now costs over $1 billion. He said, so if we think we have found something, because we will never get a chance to do a study like this again, if we think we have found something and the numbers don't quite add up, the statistical police are asked to leave the room. And there was absolute silence. And they haven't changed in spite of that. Now, very importantly, they did report an increased risk, not of estrogen alone, which decreases the risk, but of the combination of estrogen and progesterone. And in fact, there's no reason to think that progesterone will increase the risk of breast cancer, since progesterone given to women with active breast cancer is as effective as tamoxifen. But they found a statistical small, but statistical increased risk of breast cancer among women randomized to get the combination. In 2007, they published a follow-up report where they showed that it isn't that there was really an increased risk among the women who received the combination, but there was a decreased risk among the control group compared to the women who received the combination. And that was amplified in 2018 in a published article that said, you know, if you look at the increased risk, the risk of breast cancer among women randomized to estrogen alone, and the increased risk among women randomized to the combination of estrogen and progesterone, they're the same. The graphs are superimposable. So why is the combination said to have an increased risk and estrogen has a decreased risk? And the answer is, it's the control group against which the combination was compared that had a lower than expected risk. So the increased risk that was seen with the control group wasn't an increased risk, it was a decreased risk among the controls. And so the obvious question is why? Why would the controls have a decreased risk? And what was found is the controls included women who had been taking hormones before they joined the study. And if hormones decrease the risk of breast cancer, then the control group might have a decreased risk as a result of the women who had taken hormones before being randomized to placebo. And if you repeat the data calculation, just eliminating those women who had taken hormones before being randomized to placebo, the increased risk among the combination users disappears. And although they acknowledged that in 2007, and it was highlighted in 2018, and I know, because I have personally communicated with the Women's Health Initiative investigators about that, they choose to ignore it. They don't even respond when I write editorials commenting on it, and the editorials are shown to them before being published. They offer no response, and they go on saying what they've been saying for 18 years.
It's just shocking.
Yes.
And meanwhile, all these women continue to suffer, and it's, you know, it shouldn't come down to women, you know, like myself and all these other fantastic menopause campaigners who are screaming to be heard and asking for change. And, you know, a lot of the doctors we speak to are doing some fantastic work in getting a lot more education out there for doctors and also in medical school. And with the kid, I mean, the good thing that Diane has managed to do with the Make Menopause Matter campaign over here is we finally got it being taught in schools. So girls and, well, boys and girls are now going to learn about the changes that will happen after. We tend to stop when women have babies and we don't learn anything else. So it's slowly, but it's pretty shocking the amount of emails we get. And Avrum, I want to talk to you about, in chapter 8, can breast cancer survivors take estrogen? I know it's very personal to you. Your wife and your daughter have both had breast cancer, and they were both, they are now, or were, I assume, on HRT. There's a lovely quote in the book. I know it's not your quote, but it says, "It's easy to make perfect decisions with imperfect information, but medicine asks you to make perfect decisions with imperfect information." And this is about risk versus harm. Talk to us about breast cancer survivors and whether estrogen can help them, and is it safe, and how they should make that informed decision with their doctors.
Let me say again, they should make it with their doctors, absolutely. But that question has been asked by 15 studies of that question. Women who were given hormones after being treated for breast cancer compared to women who were treated for breast cancer and didn't get hormones. 15 studies published in the medical literature between 1995 and 2013. And all 15 studies show no increased risk of recurrence among the women who were given hormones. And by the way, pregnancy after a diagnosis of breast cancer, which raises the circulating level of estrogen and progesterone by at least tenfold, has no increased risk of recurrence associated with the pregnancy. And that was true even among women who were BRCA positive, women who carried the gene mutation, got breast cancer, and were treated for their breast cancer. And even they could get pregnant after breast cancer and not have an increased risk of recurrence. And an international study published last year found that that's true even for women who had estrogen receptor positive breast cancer. And so the question is, well, if there are 15 studies like that, why doesn't everybody accept that? And the answer is, of the 15 studies, 14 were called observational studies, prospective observational studies, meaning, yes, this was done prospectively. Women received hormones, some did, some didn't get hormones, and they were followed for long periods of time, up to 26 years, without seeing an increase. And parenthetically, 3 studies found a decreased risk of recurrence among the women who received hormones. But people argue, if it isn't prospectively randomized, it's not a good study. Well, I have 2 answers for that. One is, one of the 15 studies, called the Stockholm study, that not inappropriately was organized in Stockholm, Sweden, was a prospective randomized study followed for 10 years that also showed no increased risk of recurrence after treatment for breast cancer among women who were randomized to receive hormones. But the other answer is, when you look at observational studies and compare them to randomized controlled studies, and this is elaborated on in the book, a well-controlled observational study has the same validity as a well-controlled randomized study. And if you look 20 years in the future after publication, the results of observational studies are still valid in 87% of observational studies and in 85% of randomized studies. Now, I mentioned there were 15 studies, and I left out one. There is one study called the HABITS trial, and HABITS is an acronym for hormone replacement therapy after breast cancer. Is it safe? This was also done in Sweden, but not the Stockholm study, and this also was a randomized trial. And this trial found an increased risk of breast cancer recurrence. And everyone who is antagonistic to hormone replacement therapy quotes only the HABITS trial out of all the 16 that have been reported. So let's look at the HABITS trial. First of all, the follow-up was 2.1 years. That's not a very long time. And I mentioned that some of the other studies reported between 1995 and 2013 went on as long as 26 years. More importantly, if you're going to do a study where you're going to randomize patients or allocate patients after breast cancer to receive hormones or not receive hormones, you want to know whether any of those patients had recurrence of breast cancer before entering the trial. HABITS didn't do that. They did no pre-study evaluation. They didn't even do a pre-study mammogram on patients entered into that study. In addition, if the recurrence is real, you'd expect it to be most pronounced among women whose breast cancer had lymph node positivity. And there was no increased risk of recurrence among women who had positive lymph nodes. There was also no increased risk of metastatic breast cancer and no increased risk of death from breast cancer among the women who were randomized to get hormones. And yet that study is the one of the 16 that is often referred to. Yes, it is shameful.
It is shameful, and I know that I won't name anyone, but there's a few women watching tonight who the journey they have been on. It's hard enough being diagnosed with breast cancer, but then having to fight their oncologists, their gynecologists, their GPs, after doing their own research, some of which we've helped them with, and they're still being refused it, and they're spending money they don't have, traveling hundreds of thousands of miles to see a private specialist who will give it. It's criminal, and it's just not acceptable, and it's shocking. And it makes me very angry, because nobody should have to suffer, like some of these women are suffering. And we need to make change. And I do want to get through. There's so many questions coming in, Avrum. Very quickly before we go on to questions, at the end of your book, there's a chapter entitled "Debates, Decisions, and Final Lessons in the Case for HRT." And there's a woman, Susan Love, who said no to HRT because we are medicalizing a very natural phase in all women's lives. And her theory is that there was estrogen poisoning from puberty to menopause. There was a horrible article today, actually, in one of our English tabloids, who basically told all of us women just to shut up and put up and stop talking about it, which doesn't help any of us. Talk to me very quickly before we go on to questions, what your take-home message would be for these sort of non-believers.
Well, I have to address the people you just spoke about. First, Susan Love. Susan Love was a breast surgeon at Harvard. She then came to UCLA, where she was the head of breast surgical service. And Susan and I have had several debates about this. Mm-hmm. And Susan was, I believe, asked to leave UCLA because what she was saying simply was not defensible. And there's an article in the New Yorker magazine written by Malcolm Gladwell, headlined "Why Women Shouldn't Believe Susan Love." And as you point out, when we debated, I explained to Susan that I can't believe we won't agree at the end of the debate because it's based on data. And she got up and said, "There's no chance we'll agree because I disagree with anybody who calls menopause a disease." Well, I disagree with anybody who calls menopause a disease as well. But what is unnatural, as I mentioned at the beginning, is women living into their late 70s and 80s. And when Susan says a woman is fine until she reaches the age of 10, and then she has a turbulent life until maybe 50, when we get women like Eleanor Roosevelt and Golda Meir, that's just craziness. And that is craziness.
Yeah.
The take-home message is read this book or communicate with people. I mean, in England, the Latte Lounge, you have Michael Baum, who's one of my idols, who's one of the most prestigious breast cancer investigators in the world, who helped teach me and who happens to be your father. You also have Louise Newsom, who is very interested and committed to treating women with menopause and directing women to appropriate practitioners so they get good advice. When people hear me talk and they hear that what I'm saying is so not part of mainstream teaching, although it's moving in that direction, they're not surprised. What they'll say is, well, he's from Southern California. And people in Southern California are really a little strange and probably not very smart, and they're really looking to break into show business. Well, wait a minute. First of all, whatever I am, the book is endorsed by Michael Baum, by Vince DeVita, who's the former director of the National Cancer Institute, by Jerome Cassira, who's the former editor-in-chief of the New England Journal of Medicine, by Leslie Turnberg, who's the former president of the Royal College of Physicians. There are very intelligent people who think that reading this book or similar articles and going into your doctor prepared for the discussion is a worthwhile exercise.
Absolutely. Well, my dad is actually watching, so I might bring him on. I might bring him on at the end because he's one of your #1 fans as well. Avrum, this has been absolutely fascinating, and I've got so many questions. I'm going to start with a few that are in the chat box today. And go on. I've had 7 sent in advance. Oh my goodness, we've got hundreds, but we will try and get through as many as we can. Okay, so my grandma and her sister both had breast cancer. My grandma at 72 and her sister when she was 70. My mother is 74 and is fine. Is there a higher risk for me going on HRT? And that's from Kerry, who says thank you.
I'd love to give simple answers, and I can't give simple answers. But when I talk about HRT or pregnancy in BRCA-positive women after breast cancer being safe, it could be extrapolated to your situation. And in fact, we know that women who have the breast cancer gene mutation, which can increase the risk of breast cancer up to about 50%, sometimes even higher, what was done in these women is many of them were oophorectomized. They had their ovaries taken out because not only does this gene mutation increase the risk for breast cancer, it increases the risk for uterine cancer, for ovarian cancer, which has a much lower cure rate than breast cancer does. And in fact, removing the ovaries decreases that risk dramatically. And naturally, these women went into premature menopause. But their incidence of breast cancer was reduced by 50% after having their ovaries removed. And many people said, see, that makes it clear it's because the estrogen was inducing breast cancer. And so there are now 3 studies in the medical literature that looked at giving these women who had their ovaries removed replacement estrogen so that their quality of life was improved. And what was found is giving these women hormones after removing their ovaries had no negative effect on the reduction in their risk of breast cancer induced by the oophorectomy.
Okay, thank you. And remember, everyone, if you want more detailed advice or signposting, if you just email me, katie@lattylounge.co, we'll try and signpost you. Deborah, oh, sorry, not Deborah, Sharon. I know that this was sort of addressed in the book for women that were on HRT and then they were taken off it because of the WHI. Can women get on it again, perhaps if they're in their late 60s, early 70s? Is this something is this not a good idea, she's basically saying, if she's now been off it for a while?
Again, this has to be discussed with your physician. And let me tell you the concern. Young women, perimenopausal women, generally have healthy arteries. As we age, women and men, our arteries become narrower and narrower as a function of aging. And estrogen has the potential of causing platelets, which are small corks that circulate in the blood, causing platelets to clump. If you have circulating clumps of platelets in your body and already narrowed arteries, a small clump could block a vital artery, causing a cardiac event or a stroke or some other vascular event. So that before a woman who's either 10 years post-menopause or has been off hormones for that period of time, goes back on hormones, she must discuss with her physician a way of assessing the health of her arteries to be sure that that increased risk is not present.
Okay. Julie has asked, could you ask Avrum what's the maximum dose he recommends for estrogen, as I'm struggling really badly with anxiety and depression. I'm using 2 pumps at the moment. I'm post-breast cancer treatment and I've recently had a hysterectomy as recommended, so I can take HRT with fewer risks. Also, could you ask, could it be tamoxifen causing severe insomnia or menopause?
Okay, let's take them one at a time.
Quite complicated.
First, The dose, first, the preparation of estrogen that I've used in my practice primarily, which is not widely used in England, is Premarin. Premarin is an acronym for pregnant mare urine, which is what it comes from. It doesn't smell or taste like urine. And the only reason I use it, well, the two reasons are, first, it's the one that's been studied now for 60 years. So we have the most data about that preparation vis-a-vis benefit and risk. And second, Premarin is the only one that contains equilin, which is one of the estrogen compounds in it that has been shown to be of maximum benefit to brain health. But in fact, any form of estrogen can be put into the argument that I'm putting forth today. And the dose of Premarin that I use is 0.625 milligrams. That's the dose I start with. The dose of whatever preparation you're going to use will depend on what preparation it is. But it's not just a dose issue. If you're treating symptoms, then what you want to do is get a list of the symptoms that the patient has. And I have such a list, which I'll gladly provide, Katie, if asked for, where a woman can grade whether the symptoms are present, how much they interfere with the quality of her life, and the dose should be titrated against the symptoms. In addition, one could get circulating levels of both estradiol, which is the most active estrogen compound in the bloodstream, and follicle-stimulating hormone, or FSH, which is the hormone secreted by the pituitary gland to stimulate the ovary to make estrogen. And the dose can be titrated against both the symptoms, which is the best way of doing it, and the hormones. The FSH should come down to a normal level if an adequate level of estrogen replacement is being administered. As far as tamoxifen is concerned, yes, tamoxifen might cause some of those symptoms, and that has to be discussed with your physician. As far as taking tamoxifen with estrogen, that's something that has to be individualized. I can quote articles for and against that, and there's no clear accepted consensus on that issue.
Okay, thank you. I mean, we've got so many here. I'll keep going for a little bit and then we'll have to wrap up. This is an email I got in advance. Dear Katie, I cannot express in words my delight at finding this event, as I'm desperately looking for sound medical advice. I've had breast cancer treatment, bilateral mastectomies for invasive ductal breast grade 3, stage 2. I mean, this is quite complicated. She's also had chemotherapy, score was 31. But she was very ill during treatment and was given time to recover and then prescribed tamoxifen, which didn't agree with her. Nausea, headache, hot flushes, everything came back. She's become so anxious. Her oncologist has insisted that she continues, but after a year of hell, she's stopped. And she's had her ovaries removed and was prescribed anastrozole in September, and all the symptoms elevated again. She stopped taking them a week ago, and her oncologist now wants her to try a different brand. But basically what she's asking is, she's terrified of the symptoms returning, as she was so close to suicide when she was on anastrozole. I question is, having decided not to take the estrogen blockers, have I any other options that will allow me to have a good quality of life? I'm also BRCA2 positive. I'm desperate for help. My life has been destroyed, not by the cancer, but by the cruel treatments robbing me of hormones, with no joy left in my life. That's quite detailed.
Yes, it's also quite sad.
Horrendous.
First, as we say again and again, this has to be discussed with a physician. I take strong issue with either the way you are phrasing it or the way your physician is speaking, where you say, my physician insists. That's nonsense. You hire your physician, or the National Medical Service hires your physician to offer you advice, not take over your life. And your physician should be able to advise you about relative benefits and risks vis-a-vis what the next step is. Frederick Douglass is a very famous former slave who debated Abraham Lincoln in the United States before the Civil War. And Frederick Douglass is quoted as having said, power concedes nothing without a demand. It never has, and it never will. I think that's very true, and physicians are advisors, not all-powerful masters.
Yeah. Okay. I'm going to read a couple more here from up here. I'm 42 years in remission from stage 3 breast cancer, says Amanda. I take anti-estrogen medication and I'm very concerned about the long-term impact of this on my heart and my brain. I'm wondering if there is a specific period of time that I get the most benefit, i.e. is it the first 2 years or longer? I know that Zoladex is for a minimum of 5 years. Thank you.
I'm afraid that that has to be discussed with your physician who really understands the extent of your cancer, what your risk of recurrence is. I can tell you there is now a field called cardio-oncology that is looking specifically at the negative heart effects that we as physicians may be inducing by treatments that we've used with very good intentions, because these women are now living so long.
Okay. There's a short question here. Can you take HRT if you've ever had DVT?
The short answer is yes, but again, has to be discussed with your particular physician. I mentioned that the preparation I have used is Premarin, which is a pill, and I mentioned the reason I used it. The pill of estrogen does have an increased risk of hypercoagulability. It's a small increased risk. It's not large, but it's an increased risk, and I don't take that lightly. The estrogen patch has not been found to have that same increased risk of hypercoagulability.
A lot of doctors over here prefer to use patches and gels for that reason. Pamela says, can you explain the safety risks of using progesterone?
Sure. When the Women's Health Initiative first came up with the report that both estrogen and progesterone increased the risk of breast cancer, and there was that huge cessation of hormone replacement therapy, and then they found, well, actually, we were wrong, although they never say we were wrong. Estrogen actually decreases the risk of breast cancer. They had to blame somebody for their report, which, as I mentioned, is a misinterpretation of their own data, and so they blamed progesterone. There's no reason to think that progesterone increases the risk of breast cancer. Low progesterone, there's a condition called chronic progesterone deficiency. And you would think if progesterone increased the risk of breast cancer, women with chronic progesterone deficiency should have a low risk of breast cancer. They have a 5 times increased risk of developing breast cancer. I mentioned that progesterone is as effective as tamoxifen in treating breast cancer. It isn't used because progesterone also can induce nausea if given in high doses, and so tamoxifen won out. I mentioned that pregnancy, which increases the risk of progesterone dramatically, does not increase the risk of recurrence of breast cancer after treated breast cancer. So the data I'm able to glean does not support a fear of progesterone vis-a-vis breast cancer.
Okay, we have about 35 other questions. So what I'm going to do, because Avrum's given us an hour of his very valuable time, and I'm incredibly grateful, is I'm going to take a copy of all these questions, and we're going to have a look through them all and try and get as many of you signposted with the correct answers as possible. And before we go, Avrum, I'm going to see if my dad will just quickly come on. Are you there, Professor Baum? Because I'm going to unmute you. Just to say a quick hello to everyone. We've got quite a few. I can hear him.
Hi, I can give a vote of thanks, Katie.
Oh, there's my mum slumped in the corner.
A very, very short vote of thanks. Avrum, thank you for being you. You're a wonderful human being, and you're the best thing for women since sliced bread. But I've got some breaking news that will come in very, very handy. It's so important that I'll write a short piece to be posted on the Latte Lounge. It is breaking news. There is a fierce controversy going on still with this issue of hormone replacement therapy. It's swinging to our side, away from the other side, but there is still a controversy. You may or may not have heard of the Montgomery judgment, which was a medical case that went to the court because a woman wasn't told of an alternative treatment for her condition. And that was called the Montgomery judgment. And the judgment was patients must be told about other opinions. Now, that is a gross simplification of it, but from the 1st of November, the General Medical Council will make it a demand on doctors, a command on doctors. Now, the GMC can command doctors, but doctors can't command patients. They can only advise patients. And anyone who's watching here, I will give you what to say to your doctor, who themselves may not be aware of the GMC's new demand of doctors. And this is a perfect example where anyone watching will have the right word, the right reference to demand of the doctor, that he gives an explanation, a balanced explanation, using absolute numbers, Avrum, not relative risk, absolute numbers. And that's a kind of in-joke between the two of us, absolute numbers, so lay people can understand rather than relative risk reductions. So I promise you, Katie, and Avrum, I'll write a short paper on this new legislation, which will now ease the way for anyone watching this or anyone belonging to Latte Lounge to get what they deserve. And what they deserve is an informed choice.
Absolutely. And I have the power of muting my own father. That's fabulous. So, thank you, Dad, and thank you, Avrum, for giving up your time, and thank you everyone else also for coming along. And again, I must thank our sponsors, Silk Natural, who very generously allowed this event to happen. And as I said before, don't worry, we're going to go through all your questions and we're going to try and get you as much help and support and signposting as we can. So Avrum, last words from you.
Well, Theodore Dalrymple, who writes under a pseudonym, is a psychiatrist who wrote, "The more you know, the less you fear." That's exactly what we're trying to do here today. And thank you, Katie.
All right, thank you. And thank you, everyone. It's been a really interesting evening. And don't forget, you can get a copy of Oestrogen Matters. It's on Amazon and I'm sure all good bookshops as well. So thank you, everyone, and have a good evening.
You too.